All this is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. I hope you had a great weekend. Today's study is interesting. The study says that the use of vitamin C at the right time during the hospitalization or having vitamin C in the correct levels helps reduce the risk of severe disease and cut down the risk of death by 60%. So that's a great study. At the same time, there are some people who are really mad about this study as well. They are upset about it. They're angry, and there are lots of negative commentary as well. So what we'll do is three things today. Number one, we'll look at the study, what it is, and how are they proving that it cuts down the risk of death by 60%. Number two, we'll look at the vitamin D dose and see what is the right dose to have. And number three, we'll see why are people so upset about this study, and what is my point of view to look at it, maybe what is our point of view to look at it as well. And it's totally fine if you said that, hey, this is not my point of view, but let's start. And a couple of things. I had put up a question on the community part of the channel where I said, will you take a vaccine? And there are 2,600 votes now, and 46% say yes, 34% say no, 5% said only if my work requires it, and 16% said still thinking. So from the very beginning, about 100 votes in to now 2,600 votes in, the percentages have been almost the same, maybe 1% up and down here and there, that's all. And somebody just placed a comment saying, can you stop putting up clickbaity posts? Is this a clickbait post? That will you take a vaccine or not? It looks like somebody was compelled to answer. And then I don't know if you laughed about it as well or not. Yesterday on Valentine's, I put a post up, which was a little bit more invasive in the privacy. And then some folks objected and I removed it. So here is what I'm going to do. This is Dr. Bean Lectures channel. And I want to make sure that Dr. Bean Lectures channel stays clean and less controversial. I'm going to have my own personal channel started next week. Over there, we can talk other things as well. All right. So with this, let's start. Absolutely correct, Jana. Angry people are going to stay angry. Hello, Siddhartha. Hello, Lying Guys. Hello, everyone. And I saw some folks who were trying to go to Las Vegas without me. So come on, guys, I'm going to come with you as well. Okay, let's start. Discussion starting. So here is let me show you the links first. So here are the links, starting from, of course, the first thing is Dr. Bean Medical. If you wanted to earn your CMEs or CEs, this is the best place, and you can actually get it for very inexpensive rates. Then here is a study. This is not the one that I am going to discuss, but this is an interesting one. January 6th, sorting out whether vitamin D deficiency raises COVID-19 risk. So in this one, they kind of said that, well, we are not sure. And then what is more interesting is the comments at the end that I would think that are interesting to read. And I have the link in the description. This is the vitamin D and NIH. So why this I have over here is just to be able to see what are the various levels of vitamin D and what are what is deficiency and not deficiency. We have talked about this before as well. I just have this here as well. This is another older article. This is 2017. And I had used this in the past as well, where we discussed that the levels of vitamin D, daily RDA, is not really 400 international units or 800. It should be somewhere about 9,000 to 10,000 or more. And this is that article. And remember that Dr. Fauci, he takes about 8,000 international units daily. Then this is another article which is interesting from a conversion point of view, that nanomole per liter versus nanogram per milliliter. What is the difference between them? That is for the dosage calculation. This is a beautiful article where they've talked about what what various doses of vitamin D are needed for healthy individuals, then individuals with various comorbidities. For example, they've talked about oral dosages for people with the kidney disease, then for nutritional rickets, and so on. So this is a very decent article as well. Then here is the study. This study has brought a lot of pain for the authors, and I'm going to discuss that. So here is the study. I have downloaded their PDF as well. If you go here and say download this paper, you can download and read that too. I'm going to read it with you. Here is the one of the criticism thread. This is F. Perry Wilson, MD, MSc. He is, I believe, related to Medscape, columnist at Medscape and at Yale. And this is author's response to some of the criticism, which I find it interesting that they had to kind of go out and defend for everything that is already in the study. And they had to say, well, we talked about it. So let's start. Let's look at the study. Here is the study. So I have the PDF here. I'm going to go over this, but I'm going to go over on my illustrations. So let's see. Number one, the study was March 1st to March 31st. It was in Barcelona, Spain. It was an observational, non-selected clinical cohort study, which was non-randomized and open label, you can say. And they call it open randomized. And this is what got them a lot of heat as well, because people say that this is a randomized controlled trial. Randomized controlled trials have placebos in them, and they actually say it in their limitations. If I go down here to the study, again, please keep in mind that the punchline of this whole thing is reduces the risk of death by 60% and reduces the risk of severe disease by 82%. That is a punchline. We're just going to look at the study now and see what have they found and look at the doses. So if you see here, they actually say first, they in their own limitation in the paper, they're saying first, the study was not placebo controlled. So they're saying it. So when they're saying it is not placebo controlled, that means it is not randomized controlled trial. Then why do we go and attack them to say it is not a randomized controlled trial? Then they say, however, as calcifediol was randomly administered, we can consider the effect of calcifediol as an open randomized trial. Fine. Second, serum 25-hydroxy-D was not measured during follow-up. What they said was after we started administering the vitamin D, we did not do the vitamin D levels afterwards. So we don't really know at what dose, what is the effect. They just know that giving vitamin D reduced the risk. They do not know how much vitamin D or what was the minimum level and what was the maximum level. They don't know that. Fine. And then they have, this is the outcome here. So I'm going to go back here and talk about it. So what they're saying is, here are folks, vitamin D. There is another objection on this study, that they have a larger set of people who got the vitamin D and a smaller set that did not get vitamin D. So what's the difference? 551 people were given vitamin D who were hospitalized, and then 379 people were not given. And so people are upset about that as well, that this is not a one-to-one comparison. We have actually seen so many studies during COVID which did not have the right number one-to-one numbers. Even we saw with the vaccine groups that we can have actually various doses and those numbers can change. So I didn't think that this was important. You would actually see when you would read the critique for this study, why people are becoming so mad. So I was just kind of curious at why are so upset. And then I saw that they were being upset because at one point they said, you know what will happen? The anti-maskers and anti-vaxxers are going to pick this up and say, this is an excellent result, and why not we just do this, and why not we stop wearing masks or not take vaccines? And that is what I think is actually a professional and ethical inconsistency. Here is why. a doctor should present their case with data, and another doctor should look at that case with the data, instead of attacking others because some fallout would occur that they don't want. This is the same thing that happened to me on Twitter a few days ago, where this internal medicine guy, doctor, became upset with me. And the reason for him becoming upset was that I was talking about a ivermectin's possible side effect, which to him was going to cause people not to take ivermectin. And now he was upset with me to say, why don't you shut up? So that is what I was seeing here as well, that the folks are getting mad that why don't they do stop doing such trials and let us just do vaccinations. And again, I am a pro-vaccine person. So I'm not going to say that don't get the vaccine, but at the same time, if there is something good with vitamin D, why not? So let's continue. Vitamin D, folks, 551, non-vitamin D, 379. What was the observation? Number one, ICU needed or not. So again, these were the folks who were admitted in the hospital. There were 8 COVID wards. And this was another objection. I'm sorry, I'm just continuing to conflate these things because it is important. There was another objection that there were 8 wards. And then out of those 8 wards, 5 were given vitamin D. Everybody in 5 wards were given vitamin D, and everybody in 3 wards were not given vitamin D. And so the objection was, well, in a hospital, various wards can be of various specialities. For example, one ward could be cardiac issues, another ward could be orthopedics issue. And now you cannot assume them to be equal. But authors have actually very clearly written in their paper that these 8 were all COVID wards. So people just created objections without properly reading it, or they created objection thinking others will not read it. So that was the weird thing. Anyways, ICU need. Those who were given promptly vitamin D at the admission to hospital, their need for going to ICU was 5.4%, or out of them, 5.4% went to ICU. On the other hand, those who were not given vitamin D at the admission, that was about 21.1% who went to ICU. So that is a significant difference. Interestingly, authors found out that once a person is in the ICU, then trying to correct their vitamin D levels did not make any difference. Although this became an objection as well, that, hey, out of this control group, when some folks were admitted to ICU, the ICU doctors decided, and I think they did a great job of deciding this, they decided we should give them vitamin D as well. I think they tried to protect their life. It was too late for vitamin D at that time, so it didn't work. And then people started having a tantrum about that as well, that now that has broken protocol. Yes, that is a broken protocol. Absolutely correct. But look what they were trying to do and what is the outcome. Anyways, back here, ICU need 21% if they do not have vitamin D, and 5.4% if they were given vitamin D immediately on admission. Deaths. 36 people died in the vitamin D administered hospitalized patients, 6.5%. And 15% died in the non-vitamin D treated group. The p-values are significant here as well. This became another objection. So if you see here, the people from the vitamin D level, vitamin D arm that went to the ICU were 30, but the people who died were 36. So they said, well, how is it possible that somebody died without being in ICU? So it is possible that somebody deteriorated outside. And so all that data is available. So they are taking this as an incorrect reporting. They are saying they must have been in the ICU, but they are not reporting them. which I think is wrong. I have worked in the wards as well. Other doctors or nurses have worked in the wards. Sometimes somebody can become critical and they are in the ward, and there may not be a chance to bring them to ICU and they pass away before. So anyways, so this was the number of deaths, 6.5% versus 15%. The result was greater than 60% reduction in mortality in vitamin D and 82% reduced risk of the need for ICU. These are both significant and important outcomes. Another secondary outcome they found was that somebody who already had a higher vitamin D level or normal vitamin D level, they had a better chance of staying outside the ICU. They had a better chance of not becoming severe. What does that mean? That means that discussion that we've been having from the day one. My very first video after debunking the Stanford paper was about hydroxychloroquine. My second video was vitamin C. Third was vitamin D. And we've been talking about vitamin D since then. And here, once again, there is one more study. And I hope that we are keeping our vitamin D levels corrected. So management, what was the management that was happening in the hospital? They were giving hydroxychloroquine, 400 milligram on admission, then 200 milligram every day for the next 4 days, azithromycin, 500 milligram per day for 3 days, ceftriaxone, which is also an antibacterial, 1 or 2 gram per day for 7 days. In case of severe patients, they were giving them dexamethasone bolus of 20 milligram per day for 4 days. Then on vitamin D side, they had capsules of vitamin D, and every capsule had 266 microgram. So they would, on day one, they will give 2 capsules stat. I think this came to be 266 was about 10,000 international units. I think so. So maybe 20,000 international units in the day one. I have to confirm the, I am more used to international units than micrograms, but I think it is 10 or 10. So 2 capsule on the first day, then on day 3, 1 capsule, on day 7, 1 capsule, on day 15, a capsule, and day 30, a capsule. If it is me, I give that every day and I give 2 capsules every day. So anyway, so that was the protocol. Now, before we continue to see what was going on with the study, I want to look at the levels, vitamin D levels. And we have talked about this before as well. So this may be a question in your mind that, all right, so what should be the vitamin D level in me and what should be the vitamin D that I should take? Once again, as I say over here, this is not an advice for any single person here. This is not for you. Please, this is just for educational purposes. Talk with your doctor, decide and look at what is less in your body, how much vitamin D is less, and then see how to correct it. The authors here of the study, they said that instead of checking the levels, which they did afterwards, but as soon as the patient would come in, they'll draw the blood and they'll do the testing. And while they have sent out for testing, they will start administering vitamin D right away. So here is what are the doses. So look, 3.3, it is said that the dose should be 3.3 microgram per kilogram body weight. That comes to be about 9,000 units to 10,000 international units. So if you see here, for a 75 per kilogram person, 3.3 microgram multiplied with 75 is about 250 microgram. Now for 10,000 units is about 125 microgram. And 1 microgram equals 40,000 units. So 250 is 250 into 40 is 10,000 international units. So that is one. I had shared this article before where we saw that, check this one out. So they have talked about, and you can read it, they've talked about some statistical error, but here what they're saying is this could lead to a recommendation. So they're saying the correct recommendation for vitamin D of 1,000 international unit for children lesser than 1 year, on enriched formula and 1,500 international units for breastfed children older than 6 months, 3,000 international units for children greater than 1 year of age, and around 8,000 international units for young adults and thereafter. Actions are urgently needed to protect the global population from vitamin D deficiency. So here, this is a 2017 article where they're saying, please correct the daily RDA. It is not 400 international units or 800 international units. It should be 8 to 9,000 international units. So in my opinion, that is the right area as well. So back here, in here. One more thing here is, look at this, about 9,000 international units. So that is here. If you read this part with me, a statistical error, this yellow part in the top. A statistical error in the estimation of the recommended dietary allowance for vitamin D was recently discovered. In a correct analysis of the data used by the Institute of Medicine, it was found that 8,895 international units per day was needed for 97.5% of the individuals to achieve a value greater than 50 nanomole per liter or 20 nanogram per milliliter. So that is the right way to do it. All right, so once again, please talk with your doctor when you are adjusting. Now, what are the limitations of the study? The limitations of the study are the following. Number one, both groups are not equal. One is slightly bigger than the other. I don't find that to be a bigger problem because eventually you do the percentage analysis. Number two, the randomization was not individual, that one person gets A and the other person gets B. It was on basis of wards, and wards were clusters. So the statistical analysis done on clusters is done differently than it is done on individuals. So they ran the analysis on the study results as folks were individually randomized, but they were actually looking at wards. Out of 5 wards, everyone in 5 wards were given vitamin D and everyone in other 3 wards were not. Although I still believe it is valid because all 8 wards were COVID wards. And then they were able to do the age and gender and other comorbidity analysis as well. So I don't know why this became a bigger issue. Then it was not really a randomized trial. It was not a double-blind trial. That is, the patient doesn't know that they're getting vitamin D and the doctor doesn't know they're getting vitamin D. It was kind of an open trial. I am actually nowadays in favor of the open trials as well. I know people are going to come in and put a comment there that this is not science. Fine, but if you feel that vitamin D does something, then start administering it. Possibly patient clustered, so that is another. Somehow non-treated group already have lower vitamin D. So that was the interesting part, that if you look at the tables, the non-treated group, so people are getting admitted and coming in the ward, 5 wards versus 3 wards. The median vitamin D level in the 5 wards, which eventually got vitamin D, in them initial vitamin D levels was about 15 nanogram per milliliter. On the other hand, in the other 3 wards where they did not administer vitamin D, these folks, when they arrived, they had median was 12 nanogram per milliliter. So there was another objection that how come this is possible, that one group was already at a deficit. And the authors had actually put that in their paper as well, that was not such a great statistically significant difference to say the study is invalid. They had already talked about these things, but people are still kind of beating them up. And finally, the protocol was broken when those 379 people, out of them 80 ended up in the ICU. Out of those 80, 57 people were given on doctor's discretion. They were given vitamin D when they were in the ICU. Everyone else who was given vitamin D was given vitamin D at the admission. So of course, people are now upset that why were they given vitamin D at all? I actually think that they found one more important point here, and that is if you give vitamin D too late, it doesn't work. But still, yes, they broke the protocol. They gave vitamin D to those who they were not going to give vitamin D. I still feel they did the right thing, that doctor tried everything. And if they thought there is a possibility of saving someone with vitamin D, they said, to heck with the study, then let's try to give them vitamin D as well. And the objection is, then don't call it a study. I think the data is still very useful. So here we are with this data. Now what I'm going to do is I'm going to show you a couple of objections, and then let me actually just very quickly go over the study itself. So here is the study. This is the result they're talking about. This is the result they're talking about. Then here they're saying that vitamin D is very important for immune modulation and for reducing the inflammatory system. We have done this discussion. I have linked my own videos in here in which I've talked about how the immune system cells become better with this, how the cathelicidines are increased, how the defensines are increased, and how the nuclear factor kappa B is modulated. That all improves the defense capability of the cell, plus modulates immune system. So that is a function of the vitamin D. They're talking that here. Then they're talking about we have 930 people, and then they're talking about how they're separated out. In the method here, look at this. They actually say that it is a cohort prospective observational non-selected clinical study. They never say it is an RCT, randomized clinical trial. They say that it is a cohort, a prospective observational study. So then beating them up is of no use. If you don't like observation studies, simply say, I don't like observation studies, and move on. Then they say the study protocol was approved by the ethics committee. So this was another objection, that they never registered their study protocol with the clinical trials sites. And they, the authors say that we knew that you have to get the protocol registered so that you can get all the bureaucratic approvals, that the drug may not be safe, the drug may be used for the first time, so there may be hazards. So somebody has to sign off and say, let's approve this in the interest of well-being of people. And they said that because we knew that vitamin D is a safe substance and has been used before, that is why we didn't go through all the bureaucratic processes. We went to our hospital, we said, hey, we want to do this, please give us approval and we'll do the paperwork afterwards. And they gave us approval, we started doing it. I think there's nothing bad about that. And then participants here, so that is the participants, they talk about it. This is the management therapy that I've just shown you. This is the first dose of vitamin D, 2 capsules, and so on. There are the outcomes. Here are the variables. Then in the results, we just went over these. These are the results here. I'm making you familiar with this so that when you're looking at it, you can actually approach it with more confidence that these are the points that we are discussing. The limitations, we just looked at it. They say that we have no placebo arm in this one. So with this, now let's go over to a couple of more things. One thing that is interesting is, here is the author's own response, and I have a link in the description for this, to the objections. And they are saying here, I'll read just some parts, and I could not highlight it for some reason. What they said was, formal ethical approval was obtained shortly after the study started, although verbal approval from the ethics committee was given at the time it was started while we completed all the bureaucratic process. It's fine. They were in a hurry. This is irregular, but you have to understand that this happened in the setting of an exceptional epidemiological moment. And we are also sure that our intervention would be safe for patients given calcifidiol, pharmacodynamic effects, and dose employed. If it was a new drug altogether, for example, remdesivir, or some other unique drug, then they could not have started before all the protocols were taken care of. This is vitamin D we're talking about. Then they say, in addition, we never say in the article that it is a randomized controlled trial, but we consider this an open randomized trial. Fair. And then they talk about their hospital, and there are many studies there. Then they talk about another study previously, which was 76 patients only. Then they tried to add more patients and did a bigger study. So the point is, the beating up of the authors is kind of, I think, is unfair. So if you see here, this is the F. Perry Wilson, MD, MCSE, Director of Clinical and Translational Research Accelerator at Yale, columnist at Medscape, evidence-based, science-based. So he says, we need to talk about this vitamin D trial. I have no stake in this game. Take vitamin D if you want, but this preprint is super suspect. And then he has a thread where he has objections after objections, and I've talked about most of those objections. So for example, here, if you see, treated group had the vitamin D levels of 15, while non-treated had 12. So he said, why did that happen? Well, that happened. And then this, I think there are some weaknesses in the graph as well. So there's a data showing a weakness, which is fine, understandable. So anyways, the basic reason that they all became so upset were the following. That if you see here, they said, you know what, if vitamin D is taken as a solution, then nobody is going to take vaccines or wear masks. And somebody, look here, look at this. The harm is that anti-maskers, the harm of this study, that anti-maskers and conspiracy theorist types have used bad data like this. This is not really a bad data to say that masks and vaccines aren't necessary. And I don't think that anybody should use vitamin D to say masks and others are not necessary, to show distrust in public. And somebody gave an exhibit here as well. So David Davis says, this is a very important study in vitamin D and COVID-19. Findings are incredibly clear, an 80% reduction in need for ICU and 60% reduction in death. And then somebody says, vitamin D is more effective than masks. So that is science. This is not science. But then to use this to beat up science is wrong as well. So anyways, this was a bunch of interesting situation here, which I thought that at least from our point of view, you agree with the study or not, you like the study or not, at least know that what they have done, read that, and then you can disagree with the study or not. I think it is a good study. I think vitamin Ds are useful, and we should have our levels correct even now when we are home. So Golmukh says, I've already seen all this and was as exasperated as Dr. Bean is. I am just, so just like some people keep attacking me, and I start wondering that, why are you attacking me? What did I really do? I am just talking about protecting people. And then it's the same thing over here. So we medical community is not really being very straight. Okay, so how about we do this? How about we stop this here and then we chit chat again? So please do me a favor, please like, subscribe, and share. So if you're not going to subscribe or you're not going to share, at least like it. I have heard that if you like it, the YouTube's algorithm likes those videos that are liked, and then it shows it to more people. So you can help me by just liking it. So that's one. Number two, in the description, there is a link to buy me a coffee or to become my patron or to support my work. So whichever you like. If you like to support this work, please do. If you don't, that is fine as well. And I would see you in 5 minutes.